As we meet in this virtual space together, we celebrate the land that all of us work on. The City of Hamilton is situated upon the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississaugas. This land is covered by the Spoon Wampum Belt Covenant, which was an agreement between the Haudenosaunee and Anishwaabak to share and care for the resources around the Great Lakes. We further acknowledge that this land is covered by the Between the Lakes Purchase 1792 between the Crown and the Mississaugas of the Credit First Nation. Today, the City of Hamilton is home to many Indigenous people from across Turtle Island, and we recognize that we must do more to learn about the rich history of this land so that we can better understand our roles as residents, neighbors, partners, and caretakers.
Well, thank you, Valerie, for delivering that land acknowledgement. And also would just like to remind people that June is National Indigenous History Month, and we ask you to take time to recognize the rich history, heritage, resilience, and diversity of First Nations, Inuit, and Métis peoples across Canada. I also encourage all of you to take some time to reflect about the colonial history of the land you are joining from, and if you don't know, to take some time to learn about it today. So on behalf of the E-QIP team, I would like to say a huge congratulations for all of the hard work, certainly the perseverance through many challenges that I know some of you have had, and the quality improvements each of the project teams has made. Today, we are here to certainly celebrate your successes, and you all deserve a big round of applause for getting to this point in terms of nearing the end of your time with the E-QIP coaching project. So today, we are actually going to hear 5 presentations. So we're going to hear from Community Addiction Services of Niagara, Mood Walks, CMHA Toronto, Mission Services of Hamilton, Providence Care, Seniors Mental Health Behavioral Support Services, and Radius Child and Youth Services. And I actually should have advanced the slides to show you the agenda. So that is the agenda. We'll also share with you some next steps in staying connected. So without further ado, we will begin, and I will turn it over to Kason. So is that you, Jeff?
Hello, yes, I think there's a couple of us here, but yeah, I'm Jeff Sika. I'm the Director of Youth Services from CASN, which is Community Addiction Services of Niagara. So I will walk us through this PowerPoint. And yeah, like I said, I know a couple of us here, and I'm joined by Alex Laurer, who will also be helping me present, and I have to give him credit because he prepared most of this for us on our team, which is great. So you have it up here. So again, our organization is Community Addiction Services of Niagara, and our project title was Implementing OPOC Surveys. Sorry, let me know if you need me to switch the slides. It's kind of, I'm getting that circle thing on my end. Oh, here we go. Okay. So our project story: over the past few years, we have found that the completion of our OPOCs, which stands for our Ontario Perception of Care surveys, does not accurately represent the diversity of clients that we serve. It's our mission to increase the survey completion rate across programs at CASN and continue to include the voice of interested and affected parties. So I will mention that part of our current strategic plan, which is for the next 4 years, is to increase the inclusion of the voice of interested and affected parties, which includes client feedback, lived experience, and in that strategic plan, we've identified the OPOC as a main tool to collect that voice. So that's why it is a very important goal for us. So we will achieve this by the creation and implementation of an OPOC policy outlining how OPOCs will be delivered and inputted. Previously, we didn't have an actual policy on hand at our agency for the completion of these OPOCs, so that was something new for us as well. So problem opportunity statement. CASN has been conducting OPOC in person for several years. However, I think like most of us, this has been a challenge during the ongoing pandemic with virtual program delivery. So lack of regular OPOC data representing all programs and clients served gives us an opportunity to improve, unlike previously done at the end of a fiscal year. So another problem or opportunity statement that we identified was CASN cannot improve programs without any strategy to implement and review OPOC data regularly, as staff are uncertain without the information, leaving clients' needs unmet, resulting in them leaving the program and hinder staff. So I'll just kind of clarify a little bit some of the information in that slide. Just as it comes up. So where we were really succeeding with our OPOCs was our group-based activities. So for example, we have a day treatment program, we have a live-in supportive housing program. Those are easy to capture because the clients are very accessible. Where we weren't getting a lot of representation was more of our individualized services, like on our community treatment team and our youth services that were newly developed in a newer department as of January 2021. And then the pandemic, of course, affected that by people having to engage in virtual only services for a while. So we couldn't hand them an OPOC, have them complete it and collect it. It was done over links if possible. We were getting very little participation. When we started to return to in-person services, those group-based treatments were returned first. So we were starting to get some numbers roll in from that pocket, but those individualized services we were still struggling with. So that's where a lot of those problems were identified from and those opportunity statements were developed. So then our aim statements. We plan to complete 10% of OPOC every quarter with diverse CASN clients, including outreach, family, caregivers, children of loved ones who are at different points of their client journey by April 1st, 2023. So those are some of those individualized services as well as newer programs that have been developed since the beginning of the pandemic, including our family engagement coordinator role. That's a newer role that started about a year ago. Additionally, we plan to draft policies and procedures for OPOC implementation at CASN by April 1st, 2022, because again, we had no prior existing policy at our agency. So this is a very busy slide. These are a quick overview of our diagnostic tools that we walked through, and have to give credit as well to Harishi, who was our guide, and Alan, who was our OPOC expert and helped us throughout this entire journey. So you'll see on here that we have the 5W2H worksheet. I see the fishbone, our Pareto chart, and then our 5 Whys. I think he's here, but Alex, anything you want to add to this slide or say about this slide before I move on?
Yeah, I'm sorry, I was just having some technical difficulties in logging in. But yeah, I know for the 5W2H, that was really helpful with figuring out like our problem and opportunity statement, and then the fishbone, and sort of finding like root causes, and then sort of cleaning up our problem statement a little bit, as well as the Pareto chart, and sort of deciding where our main focus should be in our like aim statement. So super helpful.
Thank you. So next step brought us to our change ideas, and we went through the process of the random word generator, which is a fun one for us. And a change idea being implemented was information and training sessions for staff. We identified that there was a bit of a gap there, that some numbers may be down in areas because staff weren't comfortable or knowledgeable about not only how to do an OPOC, how to distribute it, and also the merit of them, why it is worthwhile to get them done and how it can affect our programs and services. So an information and training session was an idea, change idea that we wanted to implement. And how will we know this is working? The number of OPOCs will increase, staff will feel more educated about the evaluation tools in the agency. So here's our driver diagram. That sort of to get us on track here. So our aim statement, again, complete a minimum of 10% of OPOC every quarter by diverse CASN clients that is representative of all programs and clients who are at different points of their journey. Just to clarify that point too, is we often got an end result capture where it would be people like at the end of a treatment program and we hand them a whole bunch of OPOCs. We wanted to also show people at different points of their services in our agency So that's why we added that there rather than all towards the end at the beginning. Across that spectrum of services was important to us. Primary driver was the OPOC and the delivery of the tool. The secondary driver was unclear policy or targets. Our change idea policy to establish set amount of OPOC for each program based on number or percent. And a process measure, have targets been set? Are they being met? I see a hand up, so I thought I would just stop and see if Lucy has a question.
Just 1 more minute for time.
Oh, thanks. Talk faster. Outcome measure. Now, percentage of clients who report disagreement and our NA to OPOC sections, we identified the participation and rights area to focus on. And our balancing measure is we're not capturing client diversity across programs. Next one. These are our cycles and our PDFA planning. So cycle 1, I kind of went over this already, so I won't spend too much time on it, just how we rolled it out. Cycle 2 was the resources we put together on our P drive. Thanks, Alan, for that. Cycle 3 was including our leadership team and educating them. And cycle 4 was the completion, and we'll be reviewing the quarterly with our quality improvement committee as part of our balanced scorecard. And this is where we are, almost last slide. Outcome measure. Under the targeted section of participation and rights, we had a 97% completion rate and did not receive any feedback indicating disagree or strongly disagree. So we're very happy with that. We did well. And our process measure targets have been set to complete OPOC surveys with a minimum of 10% of clients in each program across the agency. Data is still being collected for this quarter. I can happily say we have a week left of this quarter because the end of June will be the first quarter done. 2 out of 4 of the programs have been above and beyond 10%, and our last 2 are just getting there. So we're hoping by the end of the week, first quarter, we're meeting those targets and we're right on track to do so. So it seems like what we're doing is working. And finally, lessons learned, aha moments. The most significant learning moment was the trace exercise, acknowledging how the problem could be made worse, and then generating change ideas to correct possible problems in advance. And how will you know when your project is at the point of sustainability? Our quality improvement committee, which meets quarterly, will review completion percent quarterly. We can assume that project is at the point of sustainability if targets have been met by the end of our coming fiscal year, 2022 to 2023. Just in time, that's it.
Great. Thank you. Congratulations, Jeff and Alex and your whole project team. Certainly great to see the involvement of clients, family, caregivers, and even children of the loved ones and staff in your OPOC improvement efforts. And also that you looked at your OPOC distribution at different points in times in their service delivery journey with you. And so including, resource development for staff, is a great foundation to sustaining your OPOC processes. So congratulations. And I think you've got some nice kudos in terms of the chat there.
Yes, thanks everyone for the comments as well. And I will say not only are they getting done more regularly and with more diversity, but we're learning how to use them more effectively at our agency to promote change and quality improvement.
Great. Thank you, Jeff.
Thank you.
Excellent. Okay, next I'm going to turn it over to Mood Walks. I believe Kaushi and Liam.
Yeah, thanks, Linda. Kaushi, I can share my screen. Oh,
go ahead, Liam.
okay. That's perfect. I just need someone, whoever's sharing right now, to stop sharing. Oh, it's right there. Oh, okay, fantastic.
Yep, you should have slide control, Liam.
Oh, okay. Oh, yeah, perfect. Thank you.
So we are the Mood Walk team. And good morning, everyone. I am co-presenting today with Liam. Jackie is my co-chair. She is on much deserved vacation, relaxing somewhere, hopefully under the sun. So since the pandemic, CMHA National joined a number of investigators to investigate the ongoing impact of COVID. And we know the pandemic dragged on and Canadians' mental health deteriorated with the vulnerable populations felt the most. So the third poll that was released back in May 2021, we see the results of 50% of the youth between age 18 to 24 had mental health was all-time high, and then 48% of the students and 47% of the students are youth with disability, and then 46% of LGBTQ community members, of youth members. So as you can see, that youth has been significantly impacted. So as a mental health agency, we thought about how we can reach out and support youth while they were waiting for services. So MoodWalk is one of those programs that could be easily implemented with minimal cost and some training. So for those of you who does not know about MoodWalk is a physical activity in the green space, or simply called forest bathing. So, and there are numerous benefits when you engage in physical activities or even spend time in green space. So to develop a youth-friendly model, we partnered with youth agencies supporting youth. And they have been our core partners and have been diligently working on this model. And they are CMHA Grey Bruce, Town of Innisfil, the City of Hamilton, London Intercommunity Health Centre, and CMHA Ontario. And Champlain East and Carey Place joined us during the implementation stage. So our group was tasked with researching the possibility of using the already proven program to improve and support youth's overall well-being. So as I stated earlier, the results show that two of the top most group that it negatively impacted are youth aged between 18 to 24. And we are hoping that MoodWalk becomes a tier 1 program that anyone can implement in their community to support youth mental health.
Nice. And so the opportunity that the group capitalized on was to develop a MoodWalk model that focused on youth ages 12 to 29 to support optimal physical and mental well-being. As MoodWalks is group-centered, the program will offer knowledge, empowerment, leadership, and skill-building activities to minimize current impacts that these youth are coming up against, such as inactivity, loneliness, social isolation, accessing resources, and waitlists. So with these in mind, our project aimed to refocus the core components of the already established MoodWalk program for adults, like Kaushi was saying, and modify it for youth aged 12 to 29 by March 31st, and have at least 4 partner organizations involved in delivery, testing, and evaluation. And the pilot is to be completed by August 31st, and with the final program and toolkit, hoping to release by October 31st. So,
Are we missing the fishbone?
it should be in there. Oh, I think in our version it's
down?
in there, but it's not in this version.
Okay, so we can do the
So I'll just jump.
impact and effort.
Okay, yeah, I'll just jump on this then, Kaushi. So here's our decision-making matrix after the fishbone and the Pareto chart that is not in this version, and it was created after all these tools. And as you can see, the group has set very obtainable change ideas, and that allows a nice distribution of long-term and short-term accomplishments, as you can see here.
So we had a number of quick wins that we are actually implementing. We are in the implementation stage. So those who are implemented the model, they're already practicing some of the quick wins. And the major projects that we are still working on as we continue to modify the model is the theme ideas, and then also ongoing quality improvement group. And then also we are, within the teamwork ideas, we're also looking at varying difficulties where we can engage with youth so that they can actively participate in the model and continue to benefit from the green space.
Mm-hmm. Absolutely. So for the sake of time, these are just some of the key change ideas. So training tools and resources for hikers and hike leaders, outcomes evaluations and contributions for QI, engaging with youth continuously to improve and design the model, and then as Kaushi said, locations and accessing green space. And yeah, so the mini driver diagram was to co-develop curriculum through engaging with youth to help us co-design the model. which led to the change idea that we want to involve youth from all backgrounds in the development of the program. And our process measure for this change idea is the number of youth that helped us participate in this co-design process, and as well as moving forward. And our outcome measure was the number of organizations that helped develop the pilot and evaluate the model. And we balanced this with OPOT question number 32. If another youth was in need of similar help, I would recommend this program.
So on the PDSA cycle, our team usually met on Friday mornings. So it's not an ideal time for youth to participate and contribute on the development of the model, or even to develop the evaluation question. So there we ran into some difficulties engaging with the youth. So as usual, our mighty team, the members are, as I mentioned earlier, they took it upon themselves and they went back to their own groups, the activities they ran within their organization, and then they came back with feedbacks and responses to improve involve the youth from diverse backgrounds in the development of the program. Liam, could you go back to that previous slide? And also, we also ran into some staff turnover. Their stress and the changes in the post-pandemic has contributed into expanding our implementation stage, and then also to engage with the diverse youth. So initially we had the implementation stage up until August. Because of some of the additional stresses we encountered, we expanded it until October. So then by then we will be able to finalize the model and then launch it across the province. So during the piloting phase, we had a couple of agencies pilot already completed the model, implemented it in around 8 weeks. So one of the questions that we asked is what motivated you to participate in ModeWalks? As you can see, the students' other was the highest response, and the other, when you looked at it, what are the other reasons? The students stated that they wanted to learn new skills for coping with stress and mood and mental well-being. They want to improve their overall mental well-being, and then they also want to learn more about green space and outdoor activity and increase physical activities, along with their curiosity.
Sorry to interrupt, we're at time.
Oops. Are we done? Okay.
Yeah.
Do you want to just wrap up in another like 10, 15 seconds?
Yeah.
Okay. So okay, go ahead, Liam.
Yeah. So these are the before and after mood cards. Before the walk, and then after the walk, we measure how they're feeling and base this on emojis, and then so lessons learned. Biggest awesome thing was we got a lot of support from many different associations. A learning thing was we wanted to get this out because we saw the data, but and we set really tight deadlines. So a lesson learned was maybe you can relax that going forward. And then testimonials, and as Kaushi can attest to, it's been very well.
So these are some of the words. Sorry to cut you off, Liam. These are some of the words that you described of the program that they participated. I think it just speaks for itself. Kids found it calming, relaxing, welcoming, inclusive, enjoyable, very comfy, and that's just rewarding to see these responses in the evaluation.
Mm-hmm.
Great.
Awesome.
Well, great. Thank you very much, and congratulations, Kaushi, Liam, and all of the ModeWalks team, and particularly this project, which had multiple organizations participating. We love to see the involvement of youth as you progress through your project, even though, as we know, that was certainly a challenge for you. And we'll hear this a couple times today, quick wins are really good things to gain momentum in a project. And as the research and feedback clearly demonstrates, this program has huge spread potential and can impact the overall well-being of youth. And yes, I think you'll probably see many of us love the Wordle at the end of your presentation. So thank you. And next is CMHA Toronto.
Okay. All right, let me see if I can actually share my screen this time. Somebody has to disable their sharing first.
You should just be able to move the slides on your own. Naveen has given you slide control.
Okay. It
Unfortunately,
says I cannot, yeah, okay, there I go.
yeah, unfortunately, Deneve, I'm not able to give you slide control. Your name is not popping here for me. However, we have slide control here. Once you need slides moved, we can help you out there.
Okay, great. All right, can everybody see my screen? Great. So my name is Deneve, and I'm the clinical lead with the Forensic Supportive Housing Program. And we work in partnership with CAMH. So the Forensic Supportive Housing Program works with folks who are involved with the Ontario Review Board, and they are deemed not criminal responsible. So the program, sometimes we receive referrals from the client's primary case manager in the TRIP 1 and TRIP 2 programs, and TRIP stands for Transitional Rehabilitation Housing Program. So TRIP 1 is located in North York, and TRIP 2 is located on CAMH Hospital ground, and it has a higher support staff services for clients. So usually the path is from hospital, client would leave hospital, then they go to one of our rehabilitation program, and then they would actually now be referred to the Forensic Supportive Housing Program, which is an independent apartment in the community. So the client is usually deemed ready for independent housing by their caseworkers. However, they may experience a relapse in the transitional process, whether it's through their decompensation, mental health decompensation, or they may get, begin to use substances. Obviously, that would bring on psychosis in most cases. And then we would actually just question the readiness. So what we would definitely think that the application would be premature, and the client may require additional skills and support to live independently. So the program, we will work collaboratively with the referring worker and client in developing a transition plan that may create direction for providing better outcomes. And the transition plan will be included in the referral package. Okay, next slide. So problem opportunity statement, the FSH program, as I mentioned before, have premature referrals from the TRIP programs. And how can the program assess the client's readiness within a recovery framework? And the aim statement is that we plan to develop transition plans for 100% of our new referrals to the program by June, as to determine the service user's readiness for independent living. So some of the forensic population, they've been in the hospital for some time, some of them from up to 10 years. And so depending on their treatment or response, many of them will obviously face challenges. So the diagnostic tool that we're looking at, the fishbone and the Pareto, we're looking at the cause and factors that contribute to the POP problem. So with the fishbone, if you look at the lighter dots, they are staff votes, where there's about 80% of some of the votes for staff. For example, in the people section, we're looking at, there's a lack of clarity on what readiness looks like. For example, in the policy, harm reduction versus abstinence as an indication for readiness. And then around the people section, can the program accept clients with limited ADLs? For example, if they have like limited cooking skills and limited kitchen skills, can we still accept them? So for some clients, their ADLs could use improvement. So that's one of the reasons why we're going to be using the transition plan. Next slide. So the change idea, we use the OPOC tool. We also had assistance from CAMH to help us with this. And so we did a peer interview with one of our service users that had an absolute discharge. And unfortunately, our responses were very small, with only 3 clients participating, but we were able to still use that information to develop our plan. So we tested it with clinicians and we uploaded it into our electronic medical records. And we're going to be getting feedback from clients on their experience in using the plan. Next slide. So our driver diagram, we aim to provide transition plans to 100% of our new referrals by the end of June. And the primary driver, standardized transition plan. Also secondary driver to create that transition plan. And the change ideas is research best practices for transition plan and staff training. And so process measures are there. And then if we now, the outcome measures, the number of clients who responded strongly or agree to question number 27 in the OPOC, which we'll look at the upcoming slide. And the balancing measure, staff satisfaction with the transition plan. Do they think this is going to be effective and useful tool? Next slide, please. So yeah, exactly. The PDSA, this is how we went about it. I reached out to some of the community agencies to see if they had a plan. Did not hear back from a lot of those folks. So the next thing I did a literature review on evidence-based transition plans and was able to kind of get a really good design. So once I developed that plan, I actually did a session, a staff training session. And we also recorded that session. So that's available on Microsoft Teams, just to make sure that everybody's on the same page and they know how to use that plan. And then we actually implemented that plan. I think we started at June 1st of 2022 of this year. So it's already in use. And as part of the plan, we're going to be getting the feedback, clients' feedback in using this. Is this helpful for them? Is it giving them direction? So we're also going to be documenting that as part of the transition plan. Next slide, please. Yes, Lucy. 1 minute left, right? Okay, all right. I didn't think I was going to talk so long. Okay, so OPOC survey, as I mentioned, we only had 3. The key piece is number 27. They did not feel that staff helped them to develop a plan for when they finished the program. So this actually guided us into creating this plan. And also, they also talked about that they did not have a good understanding of treatment services and support plan. So that's why we created this. And this is where our quality improvement came in. Next slide, please. Yeah, lessons learned. We are really excited. Obviously, we discovered a problem and we were able to reach out, did this project, create a new document, and now we have a new approach that's going to be assisting the forensic population as they move into independent housing. And how will we know it's at a point of sustainability? Hopefully, we will have less premature referrals and also, improve outcomes as people work, as clients work collaboratively with this plan. And I want to highlight the collaborative piece that's going to be happening. I also wanted just to say that because I came in at the last couple of months, when I got this position, I inherited this project. It was really challenging for me, but I'm just so thankful for the support that I received from Harishi and Jonathan, who is the data analyst. So yeah, thank you. I'm done. And yeah, That's it. Thank you.
Thank you, Deneve, and congratulations, and certainly a huge congratulations to you for stepping in and taking over a QI project midstream. So great work to both you and your team on creating such a meaningful and, as you mentioned, collaborative transition plan that supports your forensic housing clients as they transition into independent living in the community. Certainly it was great to see all those fantastic OPOC results with your clients agreeing or strongly agreeing with the 4 OPOC questions that you chose to measure. And clearly you've demonstrated how your change initiatives are making a positive difference in their lives. So great work.
Thank you.
So thank you. So next up, I believe we have Mission Services of Hamilton.
Thank you. I'll start off by introducing my team, Greg Croft, Victor Sear, Michelle Noyles, and Kristen Drury. And I will say that part of our learning was the changing the structure of our team. Our team started off with senior leaders, and we've changed it to a manager. Victor and I are the only original members. And Greg joined as a manager and 2 frontline workers, which was a much more effective team. So that was part of our learning. Oh, I'm trying to change the slide and I can't. Thank you. Our story really began with the Director of Addiction Services, and she was very concerned about, obviously, the opioid crisis, but also the on-site overdoses that we were seeing in our shelters and our programs. We also saw our clients changing to having increasing mental health struggles and the lack of community connections for these folks. We also noticed that our staff were finding it difficult with the amount of overdoses and some of the chronic situations with our clients. And so we wanted to build a harm reduction team. We wanted to start something very innovative for the shelter system. So we wanted to support both staff and clients. So this is how our story started. Next slide, Naveen. So our opportunity statement, for the past couple of years, even pre-pandemic, we were seeing a decline in the health of service users, an increase in overdoses and our internal reporting system, our serious occurrences, and an increased need to support neighbors as a result of the opioid crisis. A harm reduction team will improve health outcomes, reduce overdoses, build staff capacity, and provide education and resources for our service users. So we called it was definitely more of an opportunity than a problem that we were creating. Our aim statement was by December 31st of this year, we will develop a harm reduction program that will provide 1,000 interactions to individuals using our services at 4 Points Hotel, which is our overflow hotel, and our men's shelter. So let's start by looking at some of our diagnostic tools. The next one, please. Kristen will talk about the fishbone diagram.
Awesome. So as you all know, this is a fishbone diagram or a cause and effect diagram. And Michelle and I weren't part of the team at this point, but the dotmocracy strategy was used to kind of narrow in on what our team was going to focus on. So you can kind of see where all of our dots are placed on our diagram. Some of them being declining health of our service users due to substances and kind of how we can support them. We wanted more staff to support programs specializing in harm reduction. So we increased staff capacity by introducing ourselves, consistent training across our organization and so forth. So this is the diagram that kind of started us off in our project.
Next slide, Naveen. Michelle, the 5 whys.
Hi, so continuing what Kristen said, we went with the 4 whys as we were seeing an increase in overdoses, which could result in death or long-term health impacts and show need for intervention. The second one was the opiate crisis in Hamilton through our services, long-term use, alcohol use, and crystal meth use are prevented across the board, and learning that they were mixing the drugs. IV use, including the increase of diseases. The other one was the reduction. Clients were reluctant to talk because of the stigma and still fearing the fear of being kicked out of services and not accepted, the overwhelmed by the system, and trying to normalize their use and unsure really to where to begin. Their belief of always being taught that abstinent is the only reason, and the lack of individual plans, including usage and health challenges. We are able to refer to other resources, save needles, communicate to other staff, and plans would be developed to partnership with clients, speaks to the neighbors as well in our community.
Next slide, please.
Which brings to the change ideas through staff training models. Staff will feel more confident when there is an overdose, which we have started the training. So we were able to see that change as well. We know the change is making an improvement when staff reports higher confidence in offering assistance during the event, which brought us into the TRES exercise, which I thought was interesting what the TRES meant. The theory of the problem solving, a meeting exercise to design the groups identifying counterproductive things that may be doing and find ways to stop the unhelpful activities. So being able, staff continues to be overwhelmed and uncomfortable. So we're able to build the capacity of the staff and give them more belief. One-on-one staff shadowing opportunities, informal on-site debriefing. A harm reduction team acts as a resource and supports to frontline staff, which we have seen an increase of that as well. The client issues not being addressed, we noticed, so developing harm reduction plans and process to support developing these plans with clients. At the beginning, we realized that clients were really hesitant with us on signing treatment plans. They were kind of tired of all the signing and commitment. So we were able to pull that out, which made a great difference with our clients. Provide client opportunities for support and education regarding substance use, the group settings, linkage to other services, signs and awareness of dangerous use patterns, and teaching them how to use the harm reduction tools.
Okay, thank you. Next slide. We're running out of time too, so very quickly, Victor.
Yes, okay, so the impact effort drifts. So the part of the exercise is that when we first began, we had to determine what changes that we wanted to bring. And so it's an ongoing process. Some changes have been incorporated while other ones are still in the pipeline. But we had to weigh out the changes that we desired to make in regards to their impact as opposed to the effort. And so as you can see quickly on the scales there, just exactly what some of those change ideas were, the impact that they're going to have, and the amount of effort that would go into it. So I know time is tight, but that is the general overview of the impact effort grid.
Thanks. So our PDSA planning was really taking the template of the harm reduction plan. So it was just developing the plan. It was testing it with clients and then doing the cycle again. So just revamping my own alarm set. Revamping the plan until it was the plan that it is that exists today. And Kristen's going to talk about our run chart.
So this is a run chart, as I'm sure many of you are familiar with. This is just the service provider interaction one that we created. So as you can see, provider interactions per month. And then you can kind of see we've fortunately far exceeded kind of our goal at this point, which is nice to see all of our data in one place and keep us motivated.
Sorry to interrupt, we're at time. We'll have to move on to the next presentation.
Okay.
Thank you.
All right, thank you to Valerie and certainly your QI project team. And certainly recognizing early on that also including the involvement of frontline staff in your team was going to help to lead to your successes. Really want to congratulate you as well, especially with working on such a challenging issue as the opioid overdose. We know your team must be feeling very proud that you have reached more individuals than you anticipated, and that your harm reduction plan is having such positive effects on both clients and staff. And great to hear how your project has also spread your, as I did read earlier on in your last slide, how you spread QI circles in your organization and that you have developed a QI plan. So I managed to get your last slide in there in my comments. So congratulations to you and your team. Okay, so we'll move on next to Providence Care.
Wonderful, thank you. So I'm Kim Schreiber-Brown. I'm one of the members of this team, and we have several of our team members here today. Andrea Rhino is going to be co-presenting with me. She's a nurse case manager from the Belleville area. We also have Erin Lyons and Tracy Chapman from Kingston and Napanee. Kathy Baker, who is our fearless director. Vicki Willis is our lived experience facilitator. Chris Sullivan was the OPOC implementation specialist, and our amazing coach, Lori Derry from E-QIP. So our project story starts back in 2017. We've been gathering OPOC data since 2017. We've done several small PDSA cycles and small projects to improve our data quality. And in early 2021, we thought we were ready to use our OPOC data as an outcome measure for a QI project. But as part of our E-QIP involvement, we realized that OPOC had changed over time too. And they now have a caregiver and a registered client version of their survey. And we reflected that really it's often the caregiver survey that's the appropriate one for our clients. So the first thing we needed to do was not to use the data from OPOC for a QI project. We actually needed to change how we send the OPOC surveys out. So while this was going on, Providence Care's People-Centered Care and Engagement Steering Committee established a focus on care planning, specifically that every client has a care plan and that every client is involved in the development of their care plan. So these two projects actually merge together quite nicely. So our problem statement is our OPOC data indicates clients and care partners do not feel included, nor do they have a good understanding of their support or care plan. And our aim statement is by March 31st, 2023, the response to OPOC caregiver survey question 12 will be agree or strongly agree 75% of the time. And the question 12 on the OPOC caregiver survey is staff provided me with adequate, easily understandable information about my loved one's challenges, including diagnosis, prognosis, symptoms, health status, progress, treatment plan, and medications. So as many have already mentioned, we too used a fishbone to organize our thoughts as to why our OPOC data indicated that clients and care partners didn't feel included or have a good understanding of their support plan. And we too used a dotmocracy to reveal the issues that most strongly contributed to the problem. And then our Pareto chart was used to identify the vital few. So it did identify a few different foci for us. So one being the need for a care plan, but then the other being that we make sure that we get the right OPOC survey to the right person. So the caregiver survey going to caregivers and the client survey going to clients who are able to fill out that survey. And I'm going to pass it over to Andrea.
Thanks, Kim. One method we used to generate change idea was a TRIZ. We are currently testing the idea of distributing the right survey to the right person at the right time. This included reestablishing staff awareness of the OPOC, having staff think about how they communicate with clients and care partners about the OPOC. This includes multiple methods like a welcome letter, ongoing conversations with clients and care partners, sharing OPOC results every 6 months with staff to keep it top of mind for people. We will know that the change is making an improvement by monitoring the number of surveys being sent out and returned, as well as staff feedback on the new process. This is a mini driver diagram of the biggest change idea we generated as part of this project. The primary driver is lack of a standardized care plan. Secondary driver is our staff ask clients, care partners about goals of care, but we don't necessarily focus on them. So our change idea was to develop a standardized care plan that outlines both client and care partner goals. The process measure has been tweaked to line up with our corporate care plans goals, which is the percentage of clients with an active and up-to-date care plan. The outcome measure is the percent of respondents who agree or strongly agree to OPOC Caregiver 12, which is staff provided me with adequate, easily understandable information, as Kim had described previously. The balancing measure is OPOC Caregiver question 21. The wait time for service was reasonable for my loved one. We suspect adding a care plan to the clinician workload may increase documentation time, so we want to monitor wait times. Cycle 1 was all staff OPOC education that occurred February 25th, which shared our 2021 OPOC data and provided education on the caregiver and client OPOC surveys. We had 19 of 28 staff attend our live event, and wonderful questions and insights shared amongst the group. We are now into cycle 2, where teams determined how they will select which survey to send, and this was developed into a written process. Our goal was to start using this new process on April 1st, and one of 3 teams achieved this goal, with the other 2 meeting this goal by the beginning of June. This will establish our baseline data, so we do not have any run charts to share yet. And then lastly, into lessons learned, aha moments. Our aha moment, we needed to decide which survey to send, the caregiver OPOC or registered client OPOC, and when to send it before going further. What the data told us, the data prompted self-reflection and realization that we were not forming a care plan with the client and their care partners, but that this would be a valuable change to our practice and the right thing to do. The impact on our organization. While we were working on this project, a corporate decision was made around care plans for all clients. Our corporate outcome measure is the percentage of people with a current documented, easily accessed care plan. This project sets us up for success in terms of attaining our own goals as well as those of the organization. And then how will you know when your project is at the point of sustainability? That will be through our own audits as well as corporate audits, hitting predetermined benchmarks for completed care plans. That's it.
Well, thank you, Kim, and to your entire project team. And congratulations on your OPOC project successes. Delivering the right OPOC survey to the right people at the right time is certainly, as we know, vital to obtain the good feedback data. And care plans are also, as you mentioned, a vital component of support services, and focusing on this will definitely help set you up for success and improved health outcomes for your clients. So well done. And lastly, I'll turn it over to Radius for our final presentation today.
That's me, I'm muted. I am representing the Radius team and would like to just thank the members of my Quality and Safety Committee who assisted with this project. So this particular project is called Demystifying the Complaints Process at Radius. Oh, whoops, sorry. So in April 2021, Radius implemented our in-house client experience survey, And over the months that followed, the data collected showed that surprisingly few people endorse knowing how to make a complaint at Radius. So this seemed like a good target, as good a target as any for this quality improvement project. And so this is a concern for us because we pride ourselves on being client-centered and valuing the client voice. So, you know, we're concerned that we might be missing important information and, you know, possible opportunities for QI projects by not being aware maybe of certain concerns that clients may have. So our goal is to increase the rate of clients who know how to make a complaint to 70% by the end of this fiscal year. And this is measured by the item on our client experience survey that states that Radius staff explained how to make a complaint. We use similar diagnostic tools to the rest of the crew. So we used our fishbone exercise, which is quite blurry here, but there were a number of issues that our team identified for why clients didn't know how to make a complaint. And looking at the Pareto chart, there were a few items that were highlighted as potential barriers. So the process not being on the website or being too hard, that it's only reviewed once with no formal reminders, and that maybe staff don't know the procedure or they're not doing it at times in service when they're supposed to be. The change ideas that emerged, and we also did a TRIZ exercise, which was a lot of fun. And there were change ideas that emerged in one of two areas. So one area was related to reducing barriers for clients. So, you know, providing concrete and standardized documents that they can refer to, as well as updating our website to include the process. And the other side of the coin was improving procedural clarity for staff. So providing a standardized training for staff on how to deal with client complaints. This mini driver diagram focuses on the side of standardizing instructions for staff. So the goal was to develop a training video on how to deal with client, or not just client, it could be community partners as well, such as people making referrals to Radius. So we decided to develop a training video that walked through the process of what to do when a client comes to you with information, not just about complaints but also general feedback. So it ended up being a much broader process than we anticipated. So the change idea was to get our staff to complete this training on an annual basis. The process measure for that is just looking at the percentage of completion among staff, with the overall outcome measure still being that one item from our client experience survey. And we're also monitoring staff workload on indirect hours, so that we can ensure that we're not creating any additional problems by requiring this work. This impact effort grid also displays a number of change ideas that were generated during the project. And I've ticked off the ones that we have already accomplished. And I do have to credit this largely to do with us having our accreditation review earlier this week. So that was a huge motivating factor for the entire team to get a lot of this done. This is the PDSA cycle for implementing the training with staff. So we first, developed the training video and reviewed it with the project sponsor, who's our clinical director. Piloted the training with our management team, and most recently implemented the training with the staff group. And I do have quite a bit of data from this, which is pretty exciting for me, being the egghead at the organization. But not only did we get data on training completion, and currently we have, I think the number has gone up to about 77% of staff having completed it. But there were 3 questions before and after watching the video. And each of these significantly increased after watching the video, and that's statistical significance too. So I thought that was pretty cool. The training video, or we had 100% agreement with the statement, training video helped us better understand radius feedback and complaints procedures as well. So overall, very positive and promising results from the training. And as with many others reported today, I really found it valuable to draw attention to the low-hanging fruit. So the quick wins, you know, it really made a difference in increasing momentum on this project. And so by demonstrating to the team that, like, look, by doing this little bit, we can start to improve the rates. And we already had seen an increase from 44% to 50%, and most recently 60% on our client experience survey of clients indicating that they agreed with staff telling them how to make a complaint. And ultimately the goal is for, this is another change idea we had for a client-facing document that was developed. And we're in the process of implementing a client portal through our client information service. And the goal is for our intake team to make that document available to all incoming clients through that portal, so that it's always available. But again, it's also on the website, so available as needed. And that's it for me.
Thank you. I think you got in about 7 minutes. So kudos, Shauna, to you and your project team for tackling actually a very common area for improvement from client experience surveys. And certainly that's clients knowing how to make a complaint. I do know that many organizations will be able to benefit from your change ideas. And reducing barriers for clients with the client-facing document about your complaint process and the development of your training and procedural clarity for staff are great change ideas. And certainly it was, as you mentioned, as we've heard today, the value of quick wins definitely help a project gain momentum. So thank you to everyone. And I'm going to turn it over to Laura just to wrap us up for today.
Great, thanks. I will be brief. You'll notice that I had placed a link in the chat box earlier, inviting you to complete a survey for us. So if you could take a moment to do that before you log off. I do see that some members of this group have popped off. We are apologizing for being over time. But I would like to, for those of you who are able to stay, I will just run through slides. And for those of you that have stayed on, if there are any questions that you would like answered, or if you had some curiosities about any of the presenters, please type them into the chat box. And those who are able to answer them will do so. I don't know that I'll be able to open up the meeting to have a bigger discussion. But if you do have questions, please type them in the chat box and it will get back to you if it's something that we can answer. In terms of the summer months, so we just wanted to make sure that you're set up. We are heading off into the summer months, and we wanted to make sure that you're set up well and are putting some forward thought into what's next for your project work. And we've given you some bullet points here that we want you to consider. We want you to consider continuing to monitor those change ideas. So what are those measurements that you've set out for yourselves in terms of process measures? And continue to collect those. Continue to run your cycles of PDSA to make sure that you stay on top of it. Continue to meet with your project team on those regular meeting intervals that you've set out for yourselves. Consider your threshold for sustainability. So again, we've asked you to answer that question as part of the PowerPoint presentation today, but really think upon that as you move through the next few months. When will you know that you've reached that level of sustained improvement? And write that information down so that you know when you hit that, you've made it, and then you can change how you monitor your project work and change how you deliver on that. What will you continue to monitor past August 31st? So at the end of the summer, heading into September, what is it that you're going to continue to monitor? And then also thinking about those projects that might be multi-year projects or scaling up. What are those things that you'll need to start thinking about in terms of putting those pieces into place? So starting those planning pieces now to set you up for September is a really great strategy. Who else might benefit from hearing about your project? We heard a lot of you had looked at different, research, white papers, taking a look at that type of information. But there might be others out there that might benefit about hearing about your project, and you've all done really great work. So how can you advertise and share more broadly this work? And so E-QIP is through these webinars that we've recorded is a really great way. You can take that little video of your presentation and you can share it with your stakeholders and the people in your community to share your work. The other thing that we wanted to ask you to consider is, if you are working on a quality improvement project, is this project part of your quality improvement plan? So it's really important to link your quality improvement activities to your quality improvement plan. And so if you don't have a quality improvement plan, you might want to consider joining the community of practice that we have that focuses around that quality improvement planning cycle and helping you embed your quality improvement activities into a more formal quality improvement plan. Do you have new board members that are coming on? We have June is usually that month where boards meet to do their annual general meetings and bring on new board members. So do you have new senior leaders? We know that a lot of organizations are going through shifts of leadership. So we would like you to consider, is there an opportunity for you to receive some governance and leadership training? E-QIP does offer that, so please reach out, go to our website, and there's a link there that you can send us a message to let us know that you're interested in that offering. Do you have others in your organization who have an interest in learning more about quality improvement? A lot of you have used the Ideas Online Learning e-course. We would suggest that the summertime might be a good time to incorporate some of that PD learning for your staff. So if there are people in your organization or somebody in another organization who you feel might benefit from this information, please feel free to share that. And June 17th is a past due date. However, if you were planning on submitting an application, if you wanted to get it into us by the end of day tomorrow, I imagine we would probably still have time to review and assess the application. So just click on the link in the slide deck or go to our website. The link is there. If you know somebody in your community circle, community partners and stakeholders that would be interested or you think might benefit from coaching, please send them that information. We would be happy to receive that. And of course, as you know, this is a standard slide for us, but we really want you to stay connected. So even though the one-on-one coaching support is coming to an end, we still want to know, we still want to hear from you, we want to stay connected, and we hope that you would like to stay connected to us as well. So we are always here, we're not going anywhere, we're only an email away, and we're really proud of all of you, and we always enjoy seeing these presentations at the end of our coaching supports. It just kind of rounds out the sessions with you. However, as we know, QI is an ongoing activity, and we hope that you are inspired by this activity and continue on your QI journey. So thank you to everybody. Have a wonderful rest of your day. And thank you to those who did stay on to hear us out to the end.